Good evening, Dr. Phil here. Today we'll be discussing on assessment of neuromuscular blockade. Mode of assessment can be visual, tactile, mechanical, or electrical. Visual assessment. Crude indicators of recovery from neuromuscular blockade includes ability to lift up the head from the pillow continuously for 5 seconds. This is the most useful clinical indicator of adequate neuromuscular function and indicates that less than 30% of blockade of acetylcholine receptors. The following may be possible at 50 to 80% of receptor blockade, thus are not so reliable, such as opening the mouth and protruding the tongue, ability to cough, ability to generate a tidal volume of 15 to 20 mL per kg, and able to generate negative inspiratory pressure of negative 20 cm H2O. Tactile assessment. Crude indicators of recovery from neuromuscular blockade includes sustained strong hand grip strength and ability to retain a tongue depressor between clenched teeth. Mechanical assessment. Neuromuscular transmission and muscle contractility are both assessed, highly accurate in measuring onset and offset of neuromuscular blockade. Mechanomyography measures the isometric contraction force in the adductor pollicis following ulnar nerve stimulation. Accelerometry. An electrical voltage proportional to the acceleration of muscle is generated by a small piezoelectric transducer which consists of ceramic wafer with electrodes on both sides. This voltage is used to calculate the acceleration of the muscle. Since mass of the muscle remains constant, and isotonic contraction, which is change in muscle length without any change in tension, is assessed, the force of contraction can be calculated based on Newton's second law, force equals mass times acceleration. Accelerometry is used mainly in research. Electrical. It is more specific than mechanical assessment. Electromyography. In the stimulated muscle immediately prior to contraction, electromyography monitors the electrical transmission across the neuromuscular junction via two surface or needle electrodes. EMG determines the amplitude of the signal, which is the sum of the compound muscle action potentials. Nerve stimulators. Two types of peripheral nerve stimulator, those that assess the degree of neuromuscular blockade and those that identify the location of peripheral nerves to aid accurate needle placement in regional anesthesia. Peripheral nerve stimulators used to assess neuromuscular blockade is battery operated and able to deliver different patterns of square wave monophasic pulses of uniform amplitude. Misleading results may occur due to direct muscle stimulation or repetitive firing if one uses biphasic rather than monophasic pulses, or pulses lasting longer than 0.5 millisecond. Threshold current. Charge is the physical property of matter, causing it to experience a force when in proximity to other charged matter. In positive charge, there is relative excess of electrons, and in negative charge, there is relative deficit of electrons. SI unit for charge is coulomb. Current is the flow of electrical charge. SI unit is ampere. Peripheral nerve stimulator uses direct current from batteries, as DC is safer than AC. Alternating current is more dangerous than DC for similar current flows. DC shock tends to cause single muscle spasm, and the victim gets blown away from the shock. AC produces tetany at 40 to 110 Hz, and since flexors are stronger than extensors, the victim will be unable to let go of the source of the AC current. Effects of AC current on the human body. 1 mA tingling sensation, 5 mA pain, 15 mA muscle contraction and severe pain, 30 mA last chance to let go, 50 mA asphyxia from contraction of respiratory muscles, 70 mA cardiac failure and arrhythmias, 100 mA local burns and ventricular fibrillation, 1000 mA extensive and severe burns. Threshold current is the current required to elicit muscle contraction, and it's around 15 milliamps. Supramaximal impulse. An electrical current sufficient to depolarize all nerve fibers within a given nerve bundle to recruit all the muscle fibers, it is typically 50 to 60 milliamps using transcutaneous electrodes. Ohm's law. At constant temperature, current passing through 2 points of a conductor is directly proportional to the potential difference across these 2 points, V equals IR, where voltage equals current times resistance. For flow of a fluid, an analogous form of Ohm's law exists, which is pressure equals flow times resistance. Increase in resistance requires an increase in voltage to maintain a constant current. Cool, greasy skin has increased resistance. Modern peripheral nerve stimulators are able to maintain a constant current automatically by changing the internal voltage based on detected changes in resistance. Modes of stimulation. Single twitch. It is a single supramaximal stimulus delivered once every 10 seconds at 0.1 Hz. Application. It is applied prior to neuromuscular blockade as a control measurement. Assessment of block caused by depolarizing muscle relaxants where no fade or post-tetanic facilitation occurs. Limited use in monitoring degree of non-depolarizing block. 75% of ACH receptors block will show decreased twitch height. When 90% of acetylcholine receptors are blocked, single twitch disappears. Train of 4 stimulation mode. The output waveform of a nerve stimulator in a train of 4 stimulus mode is shown. 4 identical square wave supramaximal stimuli, each lasting 0.2 millisecond, is delivered at 2 Hz, where one stimulus is delivered every 500 milliseconds and it is repeated every 10 seconds. Train of 4 count. The number of twitches elicited during TOF stimulation is known as the TOF count. In normal neuromuscular function, equal twitches in response to single pulses occurs. Sustained tetanic contraction on tetanic stimulation occurs. Post-tetanic potentiation revealed by mechanical assessment only. After non-depolarizing muscle relaxant administration, the 4th, 3rd, 2nd, and then the 1st twitch disappears. Percentage of receptor site blocked. If 0 twitches are seen, 95 to 100% of receptors are blocked. If 1 twitch is seen, more than 90% of acetylcholine receptors are blocked. Tracheal intubation can be conducted. When 2 twitches are seen on TOF, more than 80% of acetylcholine receptors are blocked. This is the usual target during maintenance of anesthesia. However, TOF count of 0 to 1 may be required for complete diaphragmatic paralysis. 2 twitches seen on TOF is equivalent to 1 dBs twitch. When 3 twitches are seen on TOF, more than 70% of ACH receptors are blocked. Attempt of reversal of neuromuscular blockade can be conducted. When 4 twitches are seen on TOF, less than 70% of ACH receptors are blocked. During recovery, twitches reappear in the reverse order. Train of 4 ratio. It is the ratio of amplitudes of the 4th to the 1st twitch of a TOF stimulus. TOFR gives an objective measure of the level of neuromuscular blockade. It is given as a percentage. TOFR of more than 90% indicates adequate reversal of neuromuscular blockade. Protective airway reflexes are intact. Adequate maintenance of spontaneous ventilation is likely to occur. Graphical plot. In this graph, TOFR is 20%. 3 twitches on TOF stimulus should be present before a neuromuscular blockade reversal agent is to be administered. Reversal agent can be administered to this patient as 4 twitches are present. If after administrating a reversal agent and TOFR is still 20%, this indicates inadequate reversal of neuromuscular blockade. Full reversed patients have no fade and TOFRs of 1. Fade is difficult to assess clinically once the TOFR has reached 0.4. Comparing depolarizing neuromuscular block and non-depolarizing neuromuscular block. Cause of depolarizing neuromuscular block is a single dose of depolarizing muscle relaxant such as sugammadex is administered. Cause of non-depolarizing neuromuscular block. Non-depolarizing muscle relaxant is administered. The physiology of depolarizing neuromuscular block. Sugammadex is an agonist at acetylcholine receptor. However, sugammadex is not metabolized by acetylcholinesterase, and AChR remains activated for some minutes. Following initial depolarization and muscle contraction from ACR activation, further action potentials cannot pass down the ion channels as AChR remains activated. Muscle becomes flaccid and repolarization does not occur. The presence of sugammadex at some acetylcholine receptor sites results in decreased number of functioning acetylcholine receptors. Contraction of fewer muscle fibers results in reduced but repeatable twitch strength. Recovery starts to occur within 3 minutes as sugammadex diffuses away from the acetylcholine receptor sites down a concentration gradient and is hydrolyzed by plasma cholinesterases. Physiology of non-depolarizing neuromuscular block. Non-depolarizing neuromuscular relaxants are competitive antagonists of pre- and post-junctional acetylcholine receptors. Binding to acetylcholine receptors induces no conformational changes in acetylcholine receptors, and thus AChR are not activated. Once more than 75% of postsynaptic AChR are blocked, end plate potential produced is reduced so much so that it does not reach the threshold required to initiate an action potential and no muscle contraction occurs. Binding of AChR and non-depolarizing muscle relaxants is a dynamic process of repeated association and dissociation. Recovery occurs when non-depolarizing muscle relaxants diffuses down a concentration gradient into the plasma from which it is cleared. More acetylcholine receptors are stimulated by acetylcholine, allowing recovery from the block. Muscle fasciculation occurs during depolarizing neuromuscular blockade, but not during non-depolarizing neuromuscular blockade. There is decreased response during single twitch in depolarizing neuromuscular blockade, but no fade occurs. In non-depolarizing neuromuscular blockade, single twitch shows decreased response with fade. Tetanic stimulation. Depolarizing neuromuscular blockade shows small but sustained response, but no fade, and does not reach 100% response. During non-depolarizing neuromuscular blockade, tetanic stimulation demonstrates fade, but does not reach 100% response. During train of force stimulation in depolarizing neuromuscular block, there is no decrease in amplitude of twitches from successive stimuli, i.e. there is no fade. In non-depolarizing neuromuscular block, during train of force stimulation, there is decrease in amplitude of twitches from successive stimuli, fade is present. Post-tetanic potentiation does not occur during depolarizing neuromuscular block. However, post-tetanic potentiation occurs during non-depolarizing neuromuscular blockade, which is increase in amplitude of subsequent twitches after a period of tetany with fade still present. Block is augmented when anticholinesterases are administered during depolarizing neuromuscular blockade. In non-depolarizing neuromuscular blockade, the block is antagonized when anticholinesterases are administered. When repeated doses of sugammadex are administered after depolarizing neuromuscular blockade, phase 2 block occurs, which consists of features of non-depolarizing neuromuscular blockade. It is also known as dual block. These graphs shows the response during non-depolarizing and depolarizing block after train of force stimulation and tetanic stimulation. In non-depolarizing block, fade and post-tetanic potentiation is shown, which does not occur during depolarizing blocks. This is another graph showing depolarizing block after repeated train of force stimulation before and after sugammadex administration. Phase 1 versus Phase 2 blocks. The cause of Phase 1 block is single dose of depolarizing muscle relaxant. The cause of Phase 2 block is repeated doses of depolarizing muscle relaxant. Physiology of Phase 1 block. The presence of sugammadex at some acetylcholine receptor sites results in decreased number of functioning acetylcholine receptors. Contraction of fewer muscle fibers results in reduced but repeatable twitch strength. For Phase 2 block, presynaptic blockade results in decreased acetylcholine synthesis and release. Postsynaptic receptor desensitization and depolarization acts to repolarize the postsynaptic membrane, results in increased sodium-potassium ATPase activity. Nature of block for phase 1 is partial depolarizing, for phase 2 is partial non-depolarizing. There is decreased response to single twitch in phase 1 and phase 2 blocks. The TOFR is more than 0.7 for phase 1 block and less than 0.7 for phase 2 block. During 1 Hz single twitches, phase 1 has sustained response, phase 2 has fade. Post-tetanic potentiation does not occur during phase 1 block but occurs during phase 2 block. Effect of anticholinesterases. The block is augmented during phase 1 block and antagonized during phase 2 block. Double burst stimulation. This is the output waveform of a nerve stimulator in double burst stimulation mode when there is no neuromuscular blockade. It consists of 2 tetanic bursts of current of at least 60 milliamps. Each burst has 3 stimuli, which occurs at 50 Hz, lasting 0.2 milliseconds, and 750 milliseconds separates the 2 tetanic bursts. The heights of both clusters are identical if there is no neuromuscular block. Advantages of DBS compared to train of 4. DBS has a more exaggerated fade than train of 4. Absence of fade is usually good evidence of reversal. DBS is more sensitive at detecting residual block. In this case of residual neuromuscular block, the second cluster has 70% of the amplitude of the first cluster. Having only 2 visible twitches makes assessment of ratio of the second twitch to the first easier. Ratio of more than 90% indicates adequate neuromuscular blockade reversal. Tetanic stimulation. The output waveform of a nerve stimulator in tetanic stimulation mode is shown. It consists of a supramaximal stimulus applied as a series of square waves of 0.2 millisecond duration at a frequency of 50 Hz for a duration of 5 seconds. Tetanic stimulation can demonstrate fade even when TOF or DBS is normal, thus it is more sensitive in detecting low levels of neuromuscular blockade than TOF or DBS. Post-tetanic potentiation occurs if single twitch is given within 2 minutes after the tetanic stimulation. Post-tetanic count. Output waveform of a nerve stimulator for post-tetanic count is shown. The 5-second period of 50 Hz tetanic stimulus is followed by a 3-second pause. Single stimuli at 1 Hz is then administered for 20 times. It is used to assess the level of neuromuscular blockade when TOF count is 0. Neuromuscular blockade is transiently overcome as the tetanic stimulus triggers supranormal acetylcholine release, also known as post-tetanic facilitation. Post-tetanic twitch count described above can then be used to monitor significant degrees of block, especially in surgery where profound block is required, such as during neurosurgery or eye surgery. Post-tetanic count is drug-specific. For example, for Rocuronium, if PTC is 4, TOF count of 1 should appear after 4 minutes. PTC counts of less than 5 indicates profound neuromuscular blockade. If PTC count is more than 15, it is equivalent to TOF count of 2, and pharmacological reversal should be possible. Practical conduct of neuromuscular blockade monitoring. Monitoring the degree of neuromuscular blockade should be undertaken whenever non-depolarizing neuromuscular blocking drugs are used. Even with intermediate-acting Rocuronium or Rocuronium, residual block is common in the recovery room and can pose danger to patients, such as respiratory muscle weakness causing respiratory failure. It is preferable to assess the effect of stimulation prior to administering muscle relaxants after the patient is unconscious, as this enables the anesthetist to place the electrodes in an optimal position to stimulate the nerve but not the muscle. Apply the minimum supramaximal stimulus at which additional stimulation will not increase the intensity of the twitches. Assess the onset of neuromuscular blockade once a muscle relaxant has been given. Differing sensitivities of different groups of muscles to to non-depolarizing muscle relaxants. Recovery of one particular set of muscles does not confirm adequate reversal of neuromuscular blockade in another set of muscles. Sensitivity of muscle groups to non-depolarizing muscle blocking drugs varies. Bulkier muscles that are closer to the central circulation, such as the diaphragm and anterior abdominal wall muscles, are more resistant to neuromuscular blockers, and neuromuscular blockade wears off more rapidly. Smaller muscles further from the heart, such as the hand muscles, are more sensitive to non-depolarizing neuromuscular blockers and remain blocked longer. The patient may start to breathe or cough when there is minimal or no response to peripheral nerve stimulation, which may adversely affect surgical outcomes when profound neuromuscular blockade is required, such as during neurosurgery or eye surgery. The diaphragm is the most resistant muscle to neuromuscular blockade. 2 times the dose of neuromuscular blocker is needed to block diaphragmatic contractions compared to that needed to block the adductor pollicis. Residual block of the adductor pollicis better reflects the degree of any residual diaphragmatic paralysis. If there is no residual block in peripheral muscles, more central muscles such as the diaphragm will be fully functional. Muscles of facial expression and the larynx are much less resistant than the diaphragm to non-depolarizing neuromuscular blockade and more resistant to non-depolarizing neuromuscular blockade compared to adductor pollicis. Thus, the degree of neuromuscular blockade of the orbicularis oculi is a better indicator of laryngeal muscle neuromuscular blockade than adductor pollicis neuromuscular blockade. Indications for peripheral nerve stimulation. When non-depolarizing muscle relaxants are indicated, such as endotracheal intubation, mechanical ventilation in patients with severe lung injury, to reduce intracranial pressure, to reduce shivering, such as during therapeutic hypothermia, in patients with status epilepticus, to decrease muscle spasms related to drug overdose or tetanus, during delicate surgery, and to reduce movement in restless intubated unconscious patients for an MRI scan, to locate nerves in peripheral nerve blocks, and other indications such as physiotherapy and treatment of chronic pain, but in these settings different devices are used. Contraindications for peripheral nerve stimulation: unable to secure the airway, patient is conscious, not on analgesia or sedation, unstable bone fractures. Relative contraindications includes burns, hemiplegia, hemiparesis, and peripheral neuropathy. Complications of peripheral nerve stimulation: discomfort, pain, especially when there is inadequate analgesia or sedation. Microshock can occur. Microshock is a phenomenon where ventricular fibrillation is triggered from a current as low as 50 to 100 microamps delivered to the myocardium directly from medical devices that have electrodes in or around the heart, such as a Swan's-Ganz catheter. Avoid contact between the peripheral nerve stimulator lead wire and the external pacing catheters or pacing lead wires. Complications of non-depolarizing neuromuscular blockers: residual muscle weakness or neuropathy, especially if steroids are co-administered. Critical illness myopathy, corneal drying and abrasions, pressure ulcers, apnea and respiratory failure, bradycardia or tachycardia, hypotension or hypertension, bronchospasm, rashes, malignant hyperthermia, decreased cough strength resulting in retention of secretions, atelectasis, and pneumonia, venous thromboembolism, etc. Neuromuscular blockers and reversal agents will be discussed in a future video. Obtain family and patient consent. Provide education. Adjust the dosage or choice of neuromuscular blockers if factors affecting the potency of non-depolarizing neuromuscular blockade are present. Medications that potentiate neuromuscular blockers includes antibiotics such as aminoglycosides, polymyxins, lincomycin, clindamycin, tetracycline, other drugs such as magnesium, lithium, quinidine, calcium channel blockers, beta blockers, local anesthetics, inhalational anesthetic agents, and prior administration of succinylcholine. The magnitude of potentiation by inhalational anesthetic agents depends on the duration of inhalational anesthesia, specific inhalational anesthetic agent used, and the concentration of inhalational agent used. Rank order of ability of potentiation of non-depolarizing muscle relaxants from highest to lowest is desflurane, sevoflurane, isoflurane, halothane, nitrous oxide, barbiturate opioid, or propofol anesthesia. Mechanisms whereby medications potentiate neuromuscular blockade is by stabilization of the postsynaptic membrane, presynaptic inhibition of acetylcholine release, and combination of pre- and postsynaptic effects. Medications that increase resistance to neuromuscular blockade includes anticonvulsants, especially when taken chronically. Metabolic and respiratory acidosis extends the duration of neuromuscular blockade by ionization of a second nitrogen atom in monoquaternary amines such as tubocurarine or Rocuronium, which increases its potency. Hypothermia will result in impaired organ function, which delays metabolism and excretion of non-depolarizing neuromuscular blockers. In patients with old age, impaired organ function delays the metabolism and excretion of muscle relaxants. In healthy neonates, there is increased resistance to non-depolarizing neuromuscular blockers due to higher extracellular volume than adults. In ill or immature neonates, there is increased sensitivity to neuromuscular blockade due to underdevelopment of neuromuscular junction and other organ function. School-age children have higher resistance to neuromuscular blockade due to higher extracellular volume than adults. Electrolyte imbalance potentiates neuromuscular blockade. For example, hypokalemia results in altered resting membrane potential of the postsynaptic membrane. Hypocalcemia impairs presynaptic acetylcholine release. Correct electrolyte abnormalities as they can interfere with peripheral nerve stimulation results. In patients with myasthenia gravis, there is increased sensitivity to non-depolarizing neuromuscular blockers and increased resistance to succinylmetonium. In patients with renal or hepatic dysfunction, there is prolongation of the duration of neuromuscular blockade if the neuromuscular blocker used are metabolized or excreted by these organs. Equipment required: peripheral nerve stimulator, lead wires, black for negative, red for positive, 2 pre-gelled electrode pads, scissors or clippers for hair removal, alcohol swabs, medications as needed such as non-depolarizing neuromuscular blockers, sedatives, analgesics, anesthetic agents, emergency drugs, reversal agents, etc. Preparation of the patient: provide anesthesia, sedation, analgesia. Positioning of the patient depends on the type of surgery. If ventilating in the ICU, the head should be elevated to 30 to 45 degrees to reduce the risk of ventilator-associated pneumonia. Remember 2-hourly turning to avoid pressure sores. The extremity to be stimulated should be visible. Monitoring required includes vital signs, cardiac monitoring, ventilator parameters, sedation scales, BIS, electromyogram, etc. To avoid interference with conduction of the stimulating current, the site of nerve stimulation should be clean, dry, shaved or clipped, non-edematous, with no wounds or dressings, and absent IV or intraarterial lines. Common motor nerves stimulated by peripheral nerve stimulator to assess degree of neuromuscular blockade. The ulnar nerve is the recommended site. Electrode placement. The distal electrode should be placed on the skin at the flexor crease on the ulnar surface of the wrist proximal to the hypothenar eminence. Attach the negative lead wire here. The proximal electrode should be placed 1 to 2 cm proximal to the negative electrode, parallel to the flexor carpi ulnaris tendon. Attach the positive lead wire here. Stimulation of the ulnar nerve will evoke a response in the adductor pollicis. This muscle is more sensitive than the diaphragm and laryngeal muscles to neuromuscular blockers. Determine twitching of the thumb and count the number of twitches. If finger movement is present, this indicates that the muscle and not the nerve is stimulated. The degree of neuromuscular blockade cannot be determined if muscle and not nerve is stimulated. The next nerve is the facial nerve. In the region of the temporomandibular joint, electrode placement. The positive electrode should be placed on the face at the outer canthus of the eye. The negative electrode should be placed 2 cm below the positive electrode, parallel with the tragus of the ear. Stimulation of the facial nerve at this point will evoke a response in the orbicularis oculi. Twitching of the muscle above the eyelid occurs. Direct muscle stimulation and relative insensitivity of the facial muscles to neuromuscular blocking drugs causes underestimation of the degree of neuromuscular blockade. The tibial nerve electrode placement. The negative electrode is placed 2 cm posterior to the posterior border of the medial malleolus of the foot. The positive electrode is placed 2 cm above the negative electrode. Assess for big toe plantar flexion. Other nerves includes the common peroneal nerve and the accessory nerve. In the common peroneal nerve, electrodes are placed lateral to the neck of the fibula with assessment of foot dorsiflexion. In accessory nerve stimulation, the positive electrode is placed behind the mastoid process, negative electrode placed at the posterior border of the sternocleidomastoid. Assess for contraction of the sternocleidomastoid and the trapezius. Stimulation of the accessory nerve is not recommended, as asystole has occurred following tetanic stimulation when the upper electrode was placed anterior to the ear, attributed to stimulation of the vagus nerve via cranial root of the accessory nerve. The degree of neuromuscular blockade cannot be determined if muscle and not nerve is stimulated. Determining the supramaximal stimulus. After connecting the lead wires between the PNS and electrodes, turn on the peripheral nerve stimulator and select a low current of 10 to 20 mA. Prior to administering neuromuscular blockers, depress the train of 4 button and count the number of twitches of the muscle tested. Increase the current in increments of 10 mA and note the current where 4 twitches are observed. The supramaximal stimulus is the current where no further increase of muscle twitch intensity is observed when the current is increased. Determining train of 4 during non-depolarizing muscle relaxant infusions, such as cis-atracurium infusion to paralyze a patient with severe ARDS for mechanical ventilation. Firstly, assess the electrode position and placement. Retest train of 4 10 to 15 minutes after each bolus dose of non-depolarizing muscle relaxant or when the infusion rate is changed. Adjust the infusion rate of non-depolarizing neuromuscular blocker to achieve a target TOF count, which is usually 1 to 2 twitches. Once the target TOF count is achieved, retest train of 4 every 4 to 8 hours and titrate the infusion accordingly. Possible causes of train of 4 count being 0. Dried electrode gel, poor contact between the electrode and the skin, deficient battery power of the peripheral nerve stimulator, lead misconnections, faulty peripheral nerve stimulator, inadequate stimulating current, neuropathy or local edema. Consider retesting train of 4 in another nerve. Neuromuscular blocker overdose. Check the infusion dose and the concentration. These are my references. Thank you.